Recording in progress.
So now let us move on to the second part of our module, that is live pedigree drawing case-based discussion exercises. I request Dr. Amita ma'am to introduce our presenters, and the moderator for the session is Dr. Shagun Agarwal ma'am.
So we have now looked at the basic pedigree patterns. We have looked at softwares that can help us with the pedigree drawings. So now we are going to move on to some case scenarios. So we have Dr. Bindu Ode who will be with us, who will be presenting a few of these cases with Dr. Rupa Darshini. Dr. Bindu has done her MS obstetrics from Kakatiya Medical College, senior residency at the same college, and is at present working as a senior resident in the Department of Medical Genetics in NIMS. And she has published a clinical study on maternal fetal outcome in abruptio placentae in IJAMP journal in 2022. Welcome, Dr. Bindu.
Thank you, ma'am. Thank you for kind introduction.
And we'll have Dr. Rupa Darshini also presenting now with you. And Dr. Rupa is at present a 3-year super specialty resident at Department of Medical Genetics in NIMS. She has done her MBBS from Tirunelveli Medical College and MS from Osmania Medical College. Her areas of interest are fetal medicine, metabolic medicine, obstetrics, and fetal autopsy. And she has won various awards and accolades. So we welcome Dr. Rupa Darshini as well to present the cases.
Thank you, ma'am. So I'll share my screen now.
Okay, so before we begin, so the purpose of this session is now to take you through some actual cases and draw the pedigree step by step. And then we are going to see how by drawing those pedigrees, the clinical scenario changes, or it gives us very important clue, and that guides us as to how to move forward with that particular case. So first, I think, Dr. Rupa, we'll have to do the whiteboard. I think Vishal has enabled the whiteboard. Can you please see?
Yes, ma'am, I'm trying to. So I think whiteboard is not enabled yet, ma'am.
I can load it. I mean, like from my side, I've started a new whiteboard. So is it not enabled for you? Like there is that button of whiteboards.
Yes, ma'am. I'm clicking on new whiteboard, but it's not possible. Opening another whiteboard. Yes, ma'am, you have to close your whiteboard, ma'am. Only then I
I'm
can
doing it. Yeah, I'll close mine.
yes.
Yes, now open yours.
No, ma'am. My whiteboard isn't opening.
I think Dr. Rupa, you can use this whiteboard, which is right now also there. Anybody can draw on it. In fact, I'm also able to.
Can you share your screen, ma'am? I'm not able to see that whiteboard.
You're not seeing any whiteboard right now?
It just shows add a sticky note, ma'am. That's it.
Why don't you do it, Shagun, to begin?
Yeah.
So.
Okay.
Yes, ma'am, but just a minute, ma'am.
Like a lot of people are in fact able to draw on it right now. You're not able to, Dr. Rupa?
No,
then I'll do it if you're not able to.
Okay, ma'am. Shall I describe the case, ma'am?
Okay, just give me a second. I would request everybody to stop using the whiteboard, otherwise it is all getting crowded. Okay, maybe after we are done, we can do it. Okay, yeah, Dr. Rupert?
Yes, ma'am.
No, wait. And please don't use the whiteboard, whoever is doing right now. Okay, Dr. Rupert, tell me.
Yes, ma'am. So the first case, so a non-consanguineous couple. So the husband is 28 years old and the wife is 25 years old. And they are pregnant at 11 weeks gestation.
So then we are drawing the male, I mean the husband, which is the square, the wife who's the circle, and now this diamond is the pregnancy. So this I've drawn the diamond and written the P, and then we are mentioning here the period of gestation. I request other participants to please not use the whiteboard right now, otherwise we'll not be able to see. So here we are writing the periods of gestation below the pregnancy. And now because this couple has come for counseling, so this lady becomes the consultant. She is
Yes.
a healthy person, so she is not the proband.
Yes, ma'am. She's the husband or the wife, both are the consultants. And the husband's sister is also non-consanguineously married.
Just wait 1 second, Dr. Rupa. What's happened? Okay. So husband's sister this is the husband's sister now.
Yes, ma'am. She is non-consanguineously married. And they have a male child, first male child, who is now 8 years old. And the 8-year-old child is affected with DMD.
Okay, sure. So now what will be, she has told me, so I've drawn it. I mean, so here, this is this particular couple who has come to us and they are pregnant. So this is the pregnancy symbol we are drawing. And somebody has written they're unable to see. Are other people able to see?
Yes, we can see. No problem. Carry on.
Okay.
Okay.
So this is the pregnancy symbol with the P written, and here I'm trying to write 11 weeks right now. So because it's a pregnancy, and then I put a symbol for C. So, I mean, you can see, of course, here it doesn't look that neat, but if we draw with hand, or as Dr. Priya said, if we use one of the softwares, it could be much neater, of course. So the wife, the husband, single line means they are non-consanguineous. And here, of course, we can add their ages. She is 25, she is 28. So we write that below. And then we put this symbol, an arrow and a C, meaning they are healthy people, but they are come for consultation or counseling. So that this individual is called as a consultant. So that's a C for a consultant. So both of them are consultants. And then this is the offspring line. And then we have the diamond and the P for the pregnancy. This is the POG. And now she's told me that the husband's sister, who is also non-consanguineously married, they have a boy. And this boy is affected with a genetic condition, that is Duchenne muscular dystrophy. Okay, so I'm now drawing this lines. I can draw anything, any design. I mean, those of you who are artistic can use your talents and draw any design you wish to. Basically, we have to shade. And then after that, we have to draw a legend telling what that shading means. Because in that same pedigree, you could have multiple people. Please, other people don't draw on this. A lot of lines are coming. So we are seeing these symbols and these this is called as a legend, where now she's told me that this particular individual is affected with DMD. So I'm going to write the disease name here. In short, I'm just writing DMD. Ideally, we should be writing the full name. So this person is affected with DMD. And at this point, we need to remember that we should not take the couple's word for it, but we need to actually check whether it is DMD or something else, because there are many neuromuscular disorders which will look exactly like DMD. So if a male child is affected with a neuromuscular disease, this doesn't automatically make it to be a DMD. So it could be any of the other muscular dystrophies. It could even be some other genetic conditions like some congenital myopathies, neuropathies, even spinal muscular atrophy, which could look exactly the same. And the parent may just say that the child has DMD. Okay, so the important thing is to check the genetic report. So in this case, do they have a genetic report, Dr. Rupa?
Yes, ma'am. I'm coming to the discussion
Okay,
part.
so you show me the pedigree now.
Yes, ma'am.
So how
So
it
this
is
is the
looking?
final pedigree. So this is the final pedigree.
Make it
So
full screen.
yes, ma'am. So this is the final pedigree where we can see the couple who is pregnant at 11 weeks gestation, and the husband's nephew is having Duchenne muscular dystrophy, and which is shaded with red color. And we can also see in the pedigree that the husband's mother actually has cardiomyopathy at 60 years of age. So this is the final pedigree. So they wanted to know the risk of similar condition, that is Duchenne muscular dystrophy, in their offspring. So as we can see that Duchenne muscular dystrophy, as we all know, it is an has X-linked pattern of inheritance, and husband's nephew's affection status does not increase the risk of DMD in this couple. And risk of DMD in their offspring is same as that of the general population risk. So next we'll move on to the second case, ma'am.
Rupa, just show that again once.
Yes, ma'am.
Yeah. So like she has told, no, so basically because this person is connected through the sisters, so and this being an X-linked recessive disorder, so although she may be a carrier, but he in no way can be carrying that particular DMD mutation of the family, because otherwise he is going to be affected. As he is healthy, we know he doesn't have that mutation, so the risk to their offspring becomes same as the background risk, which is not zero. Again, we need to remember, but it is same as the background risk for any couple. And in this particular pedigree, the other interesting thing is that this lady who's a husband's mother also has a cardiomyopathy. So sometimes we need to remember that DMD in a female can also manifest at a later age with a cardiomyopathy. So it is possible that she is a DMD carrier manifesting with cardiomyopathy, and now her daughter is also a carrier, and that's why the daughter's son is affected with DMD. But she has these two healthy sons. So these two healthy sons are not carrying the mutation, because had they been carrying the mutation, they would have been affected, as DMD is an X-linked disease. So with this, like just making this pedigree, we can actually come to the conclusion that this particular family and this pregnancy is not at any increased risk of having a DMD. The background risk remains, which is true for any couple. So now we can go on to the second case. So Dr. Rupa is going to show. Dr. Rupa, I think let's try once more, but yeah, because that
1 minute, ma'am.
pedigree, yeah.
No, ma'am. Still, I'm not able to draw on this whiteboard.
Okay. So, are you able to see the whiteboard?
I'm able to see it, but I'm not able to draw on it, ma'am. I have enabled the whiteboard on my account, but I'm not able to draw. I don't know why.
Okay, just a second. I mean, if Vishal is there, can we somehow prevent other people from drawing on this?
Ma'am, it is a public whiteboard. You can't.
Okay, Dr. Rupa. I request everybody please not to draw on this whiteboard. Dr. Rupa, please tell me.
Yes, ma'am. The next case.
Yeah, so
So
again,
case 2, husband and wife, they have come to genetics clinic. They're presently pregnant at 10 weeks gestation.
What about their consanguinity status?
They are actually fourth degree consanguineous, ma'am. They're second cousins actually.
Okay.
And
okay. Then
this wife doesn't have a sibling.
hmm.
Her mother had one abortion followed by this lady who is the wife. This wife has no other sibling except for one miscarriage in her mother.
Okay. So now here I've drawn this triangle. This is basically reflecting the miscarriage in her mother. And I have connected this couple with two lines, which is reflecting the consanguinity. And here, because it's a little difficult to draw, so I'm not really connecting the whole family. But we can write here the degree of consanguinity over these two lines. So these are fourth degree consanguineous couple.
Yes.
And yeah, so and her parents are non-consanguineous.
Parents are non-consanguineous.
Okay. Yeah.
And this wife's maternal aunt, ma'am. Wife's maternal aunt.
Okay, so I'm drawing the mother sister, that is the wife's maternal aunt. Yes.
Yes. So wife's maternal aunt had two children, two male children. So who both passed away at 18 years of age and 19 years of age. And there was some history of childhood onset motor difficulty in both these offsprings.
So here, because we have to show deceased individual, that is who have expired, so I'm drawing a line. So when we draw a line like this, it shows that that individual is deceased. And then I'm going to shade them both, which is basically reflecting that they're both affected. And here then I am drawing the same legion, showing that shading. And I'm going to write that this means that some neuromuscular weakness is there. We don't know what it is. We don't have any diagnosis. All she has told me is that they had some weakness from childhood. They became wheelchair bound by teenage, and then they died by 18 and 19 years of age. That's all the information we have right now.
Yes.
So, yes, what else?
And one more information is that this wife's maternal grandmother.
Okay, means her mother's mother, right?
Mother's mother, yes, ma'am.
Right.
Mother's mother also had a sibling.
Okay.
Male sibling.
Mm-hmm.
With similar motor difficulty starting from the early childhood, and he also passed away at 18 years of age.
Okay, fine. So this is like a similarly affected individual, similar course of illness and death in late teenage, and connected through the grandmom. Okay, fine. So now let's go on to the presentation. So show the final pedigree for this family.
Yes, ma'am. So this is the final pedigree drawn with the help of Invite app. So as we can see that in this pedigree, the couple, 22 years and 25 years old couple, are married fourth degree consanguineous. They are second cousins and they are 10 weeks pregnant now. And as we can see from the pedigree that the maternal aunt had two children affected with neuromuscular disorder. And also the maternal grandmother's one male sibling also had a similar disease. So from the pedigree, we can make out that the affected people are all male. So, and as this female, this maternal grandmother and the maternal aunt are affected to more than two affected male individuals. So they are called obligate carriers. So from the pedigree, we can make out that
Dr.
there
Rupa,
was
just
some
wait.
history.
Dr. Rupa, we'll go back. We'll
Yes.
go a little slow. Just go back, remove your animations.
Yes.
Yeah, okay. So what we have here now is that we are seeing these male individuals, we are seeing all females are healthy. So that is immediately we should raise suspicion that probably it's an X-linked recessive condition. And then the other clue is that these males are all connected through these females. So and all these females are healthy. So, and then if we look at this kind of transmission, we call it as a kind of a Knight's move kind of a transmission. It's not truly a vertical or a horizontal transmission. So all these clues put together, here we are thinking that this looks like an X-linked recessive condition. So that's just the first point we are able to make out when we draw this whole third generation pedigree. The second point which we want to now ascertain is that what is the possible diagnosis? That is one. And third thing is that what is the main thing which is there is that this couple has come and they're looking at their pregnancy. So we want to find out what is the risk to this pregnancy. So now we need to understand that these males, the women through whom they are connected, these women are all basically what we call as obligate carriers. So when we draw a pedigree like this, through connections or basically by mapping out the relationships between the individuals, we are able to ascertain that who is the person in the family who is the carrier of that particular condition. So because here in this family, the basic problem is that we can't reach a diagnosis unless we do a genetic testing. And to do genetic testing, ideally you need the proband sample, that is the person who is affected sample. But here none of the affected people are alive. Okay, so in such a situation, then the option is to find the people who are the carriers, so which are basically the women connecting them. So through finding out these obligate carriers, we can actually target the testing towards them and come to a final diagnosis. That is one. And also we will see how we will ascertain the relationship and the carrier status of our patient who has come to us and see what is the risk to her. So now she's put, see these two dots in these two women. So what we have inferred is that these are both obligate carriers. Why are we saying they are obligate carriers? Because obligate as in they are surely carriers. We are 100% sure they are carriers. So how do we know that? Because this lady, that is our patient's grandmother, she has a brother with this condition, and also her daughter's sons also had the same condition. So which is basically meaning that whatever condition it is, she is carrying that particular mutation. Probably it came from her mom only. So her mom was a carrier, she became a carrier, and her brother became affected. And now she being the carrier, she has also transmitted this mutation to her daughter. And then this daughter transmitted to her sons, and the sons are affected. So any lady who has two male relatives on kind of in two, connected to two male relatives in two different generations with an X-linked recessive condition, that lady is an obligate carrier. So by making a pedigree like that, we know that this lady and this lady, because this lady's sons are affected and maternal uncle is affected. This lady's sibling is affected and grandsons are affected. So these are two women whose two relatives, two or more male relatives across two different generations are affected. So we know that these two are really carriers of this particular disease. But we are concerned about this lady. So what she is showing next is that go on
Yes,
to
ma'am.
your animation, Dr. Rupa. Yeah. So what she's showing is that when this lady is a carrier, what is the chance that her daughter is also a carrier? So the chance is 50-50 because this lady has two X chromosomes, one with the mutation, one without the mutation. So she can transmit only one to her daughter. So there is a 50-50 chance that this lady also got the mutation. And then what about our patient? So if the chance for this lady is 1 by 2, that is 50%, the chance for our patient is again 50% of 50%. That is 1 by 2 into 1 by 2, which makes it 1 by 4 or 25%. So by looking at this pedigree, we found out that this is X-linked recessive. We found out that the possibility that the lady who has come to us is at the risk of being a carrier, and that risk is 25%. So this much information now we have, and this seems to be a significant risk. So now what do we do next? Yes, Dr. Rupa.
Yes, ma'am. So because the proband were not available for testing, so we have tested the obligate carriers. So first we tested the maternal aunt. So testing of DMD was done through DMD gene MLPA, which revealed heterozygous deletion of exon 46 to 55. And the same deletion was also identified in the maternal grandmother. So as we know the mutation now, we can offer carrier testing of the pregnant lady as well. So so when we see the MLPA analysis, you can see that there is half amplification here, which means heterozygous deletion in the exon mentioned here. So in this, we can see there is a deletion of exon 46 to 55 in the DMD gene. Okay, we'll move on to the next case.
Okay, wait 1 second. So what we have found here is that eventually the lady who came to us was not found to have this deletion. So we tested the aunt, we found the deletion. It was also there in this lady's mom, but then when this lady's MLPA was done, she was not having the deletion. So which means that she is not a carrier of this DMD deletion. So again, the risk to her pregnancy becomes negligible. So by making this pedigree, basically, we have been able to do this serial wise testing, and we have been able to finally tell the risk to this particular couple. So we'll go to the next case. I think we'll see the presentation only, Dr. Rupa. Let's not do the
Yes.
whiteboard because time is also short. Yes. So you tell
Okay.
us about this case.
So in this case, as we see from the pedigree, the couple are non-consanguineous. They have come with a pregnancy which is 5 weeks gestation now, and the concern is that on the husband's side, the husband's sister's son has been affected with Down syndrome. So his karyotype has showed that he is 47XY plus 21, which means he has free trisomy 21. So now the couple are concerned whether the same condition can recur in their offspring as well. So, and there is no other family history. So free trisomy 21 is in the proband, so which occurs due to meiotic non-disjunction, mainly in the maternal meiosis. So recurrence risk in this future offspring is same as that of the background risk. So there is no increased risk in this couple because it is free trisomy 21. And we give empiric recurrence risk in this couple up to 1%. So for this 1% recurrence risk, we can either tell them the option of NIPT, or if they are very anxious, we can also suggest them for amniocentesis also. But the empiric risk is only up to 1%.
Okay, I think I'll have to correct Dr. Rupa here. I just go back, Dr. Rupa, to the pedigree. So one thing here is that, I mean, as she has mentioned, of course, that this is free trisomy 21. So this is basically a non-disjunction event which has occurred in the meiosis of this particular lady. Okay, so this is in no way now related to this particular pregnancy because this was a kind of an accidental one-off event which occurred here. So for this particular couple, if this couple had come to us, for them the recurrence risk would be around 1% plus the age risk. Because that 1% risk also, why we give for such couples is that because some women are prone to have non-disjunction, some have some mosaic trisomy 21 in their gonads also. So because of which we give an empiric recurrence risk of 1% to a couple whose previous child was affected with free trisomy 21. So again here, one of the important thing is again, because sometimes patients are not carrying the karyotype reports. They just come to you and say, my child had Down syndrome, or so-and-so person in my family has Down syndrome. So it's very important to make sure that you check the karyotype report. One thing, confirm the diagnosis. Second thing, check whether it is free trisomy 21 or not. But the thing is that the patient who's come to us is this particular couple. So for this couple, there is absolutely no relation or no increased risk of Down syndrome in their pregnancy. Their Down syndrome risk is same as the background risk because the whatever happened in this meiosis is no way going to be related to this pregnancy. So for them, the risk is just the age risk which is there, and of course you'll do the routine screening, and depending on that, whatever risk calculation is there. But definitely there is no increased risk in this pregnancy because of the husband's nephew having this particular condition. So now, but let's see another scenario of again Down syndrome, how it becomes very different from this scenario. So we'll go to the next case, Dr. Rupa.
Yes, ma'am.
Dr. Bindu, do you
Yes,
want to tell the next case, Dr. Bindu?
Yes, ma'am.
Yeah. Dr. Rupa, move the slide. Yeah, okay. Yes, Dr. Bindu, please tell this case.
A non-consanguineous, as we see the pedigree, non-consanguineous couple, currently in their second pregnancy, husband revealed that first pregnancy was terminated due to multiple anomaly, multiple soft markers, and products of conception testing, fish reveals Down syndrome. As we can see, husband's sister has a son, 3-year-old, and he's healthy. And his parents, age 55 and 58 years, are also healthy. Coming to and he elaborates a family history on his wife's side. And his mother-in-law is 56-year-old and his father-in-law is 60. They have experienced 2 intrauterine deaths before having their daughter, I mean the wife. Additionally, his elder son, who is married, gives a medical history of one missed abortion at 6 weeks and spontaneous.
We've lost Dr.
Dr.
Bindu.
Bindu
Dr.
has
Rupa,
lost his
please
connection.
carry on. Dr. Rupa.
Yes, ma'am. So from the wife's side, wife's brother had 3 miscarriages, early first trimester miscarriages, and 2 IUDs in the wife's mother as well. So now, previous child had Down syndrome, which was confirmed through FISH. So now in the current pregnancy, they want to know what is the recurrence risk of Down syndrome. So, so the Down syndrome baby which was terminated has been confirmed through FISH technique. So this does not give us the type of Down syndrome in the baby. It can be because of translocation type, or it can be because of free trisomy 21, which can be determined only through a karyotype, which was not done previously. So now, as we don't have the sample of the proband, we have to go ahead with couple karyotyping only, which was recommended to look for carrier status of any balanced translocation. And mother was found to have a balanced translocation involving chromosome 14 and 21. So which is represented as 45XX ROB 1421 Q10 Q10. So as we can see, the mother is a carrier of balanced translocation involving 1421. The recurrence risk of translocation type Down in present pregnancy and future offspring is 5 to 15%. And invasive prenatal testing is recommended because the risk is quite high. And NIPT should not be considered in this couple because the Down syndrome risk in this couple is high. And we also should recommend karyotyping of the wife's sibling also, because they are also having 3 recurrent miscarriages.
So the important message from this case is that very often now, especially now that we have here FISH was done, but very often nowadays we are using microarray for prenatal testing for diagnosis of Down syndrome also. So we need to just remember that even if a particular pregnancy is diagnosed to have Down syndrome by any and you have taken a decision for that pregnancy, but you need to remember that unless you've done a karyotype for that fetus, you don't really know whether it was a free trisomy 21 as we saw in the first case, or whether it was part of a translocation. Because if it's part of a translocation, then the recurrence risk figures change, and your subsequent pregnancy risks and management options, whether you'll do screening, use NIPT, use prenatal testing, all that changes. So here then, at least if you have taken a decision based on an array or a FISH report for a previous pregnancy, at least for the next pregnancy, we need to do a couple karyotype to make sure that none of them are having a balanced translocation involving chromosome 21, because this would really change the further options which we are going to give them, as we have seen here. So let's now go quickly to the next case.
Yes, ma'am. So this couple, as you can see from the pedigree, they are they are not consanguineous. So we can see that symbol C. So this couple has come for genetic counseling because the wife is concerned that on the husband's side, the husband's two siblings, one male and one female, have been affected with some genetic disorder, and they have been having the symptoms since teenage, means adolescent age. So they were having symptoms of imbalance and neuropathy. And the husband's parents have been married second degree consanguinously. Second degree consanguineous is marrying the own maternal uncle. So 2 of these siblings were found to have been affected with Friedreich's ataxia. So, but these 2 people are non-consanguineous. So the most common adolescent form of ataxia with neuropathy is Friedreich's ataxia. So mutation testing of the siblings revealed homozygous GAA triplet repeat expansion in the FXN gene locus. So Friedreich's ataxia is autosomal recessive condition, and the parents are obligate carriers. So the risk of the husband being a carrier for Friedreich's ataxia is 50%, that is 1/2. And the general population carrier risk of Friedreich's ataxia is 1/60. So this will be the carrier risk of the wife. So hence the recurrence risk of Friedreich's ataxia in this couple would be 1/2 into 1/60. So carrier testing of husband was offered first because they are not pregnant yet. So, which revealed that he is not a carrier. So, hence, recurrence risk in this couple was declared to be almost negligible because single partner carrier status in an autosomal recessive disorder does not increase the risk of disease manifestation in the offsprings.
So here, this case, one important point to remember is that very often couples come and they give history that there is consanguinity in the family. There are many people who are consanguineous in the family, and there is a misconception amongst practitioners also that if parents of the wife or parents of the husband are consanguineous, that increases the risk to this couple's offspring also. So that is not really true as such. So again, by it is important to sit down and make these pedigrees, check who is consanguineous in the family and how it could have a bearing on this couple. Because it's just a history of consanguinity in the family doesn't always increase the risk to that particular couple. It's important to ascertain the relation of those consanguineous individuals with this couple and then go step by step to see what is the possibility of this couple being carriers of same condition. So here, because Friedreich ataxia is a relatively common condition and the background population carrier risk is rate is around 1 by 60, that is just little less than 2%. That's why here still there was a slight possibility that the wife could be carrier of Friedreich's ataxia and husband also could be, because he could have got the mutation from one of his parents. But some very rare condition, suppose the siblings were affected, then even if the husband was a carrier, the possibility that wife also could be carrier of that extremely rare condition would become very, very low. And then the risk to their offspring would become negligible. So again, we have to, see all these scenarios, check carrier frequencies for individual conditions, and then come to conclusion as to what next tests need to be done. And luckily here, because husband himself was not a carrier, so there is no question of checking the wife and no risk to their baby. So let's go to the next case, Dr. Rupa.
Yes, ma'am. So this is a pedigree of a third degree consanguineous couple. As you can see, they are first cousins. That is, they the husband's mother and the wife's father, both are siblings. So they had a very bad experience in the sense they had two offsprings who died at 3 months of age due to suspected metabolic disorder that is propionic acidemia. So their TMS report revealed that there was elevated C3 levels. So elevated C3 level can be because of multiple conditions such as propionic acidemia, methylmalonic acidemia, and also in B12 deficiency. So we are just with the suspicion that the babies might have been affected with propionic acidemia. So, but the molecular genetic testing was not done, so exact diagnosis is not known. So as we have the TMS filter paper available, so we had ordered for whole exome sequencing from the dried blood spot DNA, which revealed homozygous pathogenic variant in the PCCA gene, confirming the diagnosis of propionic acidemia. And later, a trio-exome analysis was done, where a couple's exome sequencing was analyzed together with the child's data, which revealed heterozygous carrier status in the PCCA gene in both parents, and they were found to be no significant carrier status was found in other genes. So now the couple exome sequencing served to determine the propionic acidemia carrier state also, and as well as expanded carrier screening because of third degree consanguinity. And also in the expanded carrier screen, we also offer SMN1 gene MLPA, which is for spinal muscular atrophy carrier status, and also hemoglobin HPLC for all reproductive couple as a part of routine carrier screening, because these two diseases are very common in India. So they are 5 weeks pregnant.
Here, one important, so we can offer them prenatal also. So the important thing again is that we need to make a molecular diagnosis to offer prenatal. Very often there is some label, diagnostic label given to previously diseased children without a genetic workup. So here, as she mentioned, that the metabolic workup showed that there was some metabolite in the dried blood spot of the babies, but there was no genetic report. So unless we have a genetic report, we cannot tell what is the final diagnosis. We cannot tell what is the recurrence risk, and we cannot do the prenatal testing. So the first step is to do a molecular testing. Again here, luckily, the dried blood spot of the one of the baby was available. So these things we should inquire for very often, because couples are not aware of these things. So whenever a metabolite test is done for a previous child, a newborn screening test in the form of TMS or tandem mass spectrometry, then basically it's done on a dried blood spot. So some filter paper is taken on that, few blood spots of the baby are taken, and these are used for the biochemical test. But these blood spots are stable, and most labs store them for at least an year. And if we ask them, they can store for a longer duration also. And from that dried blood spot of the child, we can extract the DNA, and we can do genetic testing and find the diagnosis of that child. So always inquire couples whenever you have such histories. If a TMS test was done or a newborn screening was done, then it is possible that the child sample could be found, and you could offer testing there. And another thing, another sample which can be used, and that is a practice, a cultural practice very prevalent in our state, and I think in other South Indian states also, is to preserve the cord segment of the baby. So many couples preserve the umbilical cord of their babies, and even these can be used. Even a dried umbilical cord can be used for extraction of DNA. So we need to ask these leading questions from the couple, so that if some sample of the baby is available, that's the best sample to do a genetic test. And here, as Dr. Rupa mentioned, because they were consanguineous, so they also opted for doing an expanded carrier screening to check whether they were carriers for any other diseases. Again, another scenario could have been that there was no sample of the babies available. So in that case also, because two babies are affected, of both the genders, couple is consanguineous. So we are looking at probably an autosomal recessive disorder. So an autosomal recessive disorder will happen only if both the parents are carriers, or again, to use the term, obligate carriers. So if you don't have the children sample available, then the next best option is to do carrier testing of the couple by exome sequencing and find the mutation in them. And that also will help you in retrospectively by proxy, finding the diagnosis of the previous child and offering prenatal testing. So yeah, let's go to the next case.
Next case. So this case 7. So we can see from the pedigree that this couple have come with 10 weeks pregnancy. They had actually terminated one pregnancy at 16 weeks gestation with the early TIFA findings suggestive of holoprosencephaly, but no genetic testing has been done from the baby's DNA. And on further history taking, they were revealed that from the husband's side, husband's own brother had moderate intellectual disability, and one more sister was normal. And on further pedigree analysis, we see that on the paternal side, the husband's father's sister, that is paternal aunt, died at 10 years of age due to seizure disorder. And also on the paternal side, the father's one more elder brother had one child affected affected with cleft lip and palate, which was operated during childhood. So we have people on the paternal side affected with probably a CNS malformation. Like one person had seizure disorder, one had intellectual disability, and the other had cleft lip and palate. And his own offspring had holoprosencephaly. So genetic testing was not done. Now the pedigree pattern is suggestive of an autosomal dominant disorder in this family. On examination of the husband, he had microforms such as central single incisor and hypotelorism. And because he had these microforms, we were suspecting a minor degree of holoprosencephaly manifestation in him also. So exome sequencing was done in the husband, which revealed a heterozygous pathogenic variant in the 6-3 gene. And we were able to offer prenatal testing for this couple because it has 6-3 gene related holoprosencephaly, has autosomal dominant pattern of inheritance. And we also have to note that around 18 to 25% of holoprosencephaly have a monogenic etiology, which should be evaluated through exome sequencing. And we also can see from the pedigree that there is variable expressivity in this family, where one has seizure disorder, one has a CNS malformation, one has only mild to moderate intellectual disability. So the intensity, the severity, and the systemic manifestations can vary among individuals of the same family having the same mutation. So it is called variable expressivity. And also incomplete penitence is noted. That is, people having the mutation can also have no manifestation at all. And prenatal testing in these kind of cases becomes tricky. You would like to add something more, ma'am?
Yes. So here the most important point to realize is that I mean, as imaging specialist, very often you would see a holoprosencephaly on the scan. So, and we know that yes, a majority of holoprosencephaly, around 45-50%, is because of chromosomal abnormality, primarily trisomy 13. But an easy bedside kind of procedure or a bedside examination you can do is to take a look at the parents. So take a look at the pregnant lady, take a look at the husband, and try to see these micro forms of holoprosencephaly, which are nothing but these subtle facial features like hypotelorism, that is, the eyeballs are placed closer together than usual, or you could have a single central incisor, that is the upper incisors. The central incisors, instead of being two, are single. So basically they are fused. Some people may also give you a history of a repaired cleft also, or you could be having some unusual facial like kind of a nose shape or eye appearance. And also there could be certain appearances in the face of the husband or the wife which can immediately tell you that this is probably not a chromosomal etiological holoprosencephaly. It is a monogenic or a single gene disorder, which is presenting as holoprosencephaly in the fetus and has a milder manifestation in one of the parent. So this can actually guide you towards doing the correct test also, whereby you don't even need to offer a microarray. You can straight away go ahead and do an exome sequencing for the fetus to make the molecular diagnosis. And of course, it helps us in a recurrence risk prediction because of trisomy 13. If it is a free trisomy 13, and that is the cause of holoprosencephaly, the recurrence risk will be just 1% around. Whereas if it's a single gene disorder, one of the parent is having holoprosencephaly mutation, then the recurrence risk becomes 50%. So doing an examination of the parents is extremely important for some conditions like holoprosencephaly. And as Dr. Priya mentioned, if you have arthrogryposis, then check the parents, especially the mother, for manifestations of myotonic dystrophy. And the simplest thing to do is just ask the lady to grip your finger in her fist and ask her to suddenly open it. And if she's not able to open it, means she has a grip myotonia, which is one of the classical findings of myotonic dystrophy. So a fetus with arthrogryposis, mother with the grip myotonia, you have your diagnosis there. It is myotonic dystrophy, and it will not be picked up by doing exome sequencing, karyotype, microarray, nothing. All you have to do is a TP-PCR. So this gathering these clues are very, very important. Making these pedigrees, gathering these clues from all possible angles, taking a look at the parents really helps us often in making a kind of a spot diagnosis, at least suspecting certain diagnosis, so that you can do the correct testing and you can provide more accurate counseling for them. So I think quickly we'll go to the last case, and then I think
Last case.
Yeah.
Yes, ma'am. So this couple had come to the genetics clinic. So two of their offspring, two were male. One was 7-year-old and one was 5 years old. Both were having clinical features of growth hormone deficiency, mild intellectual disability, short stature, and on molecular genetic testing, whole exome sequencing was done for the elder child first, and which revealed a pathogenic variant for Schaaf-Young syndrome. So the gene involved is MEGEL2 gene. So the same mutation was checked in the younger sibling as well because he was having the similar clinical findings. So he was also found to have the same mutation. So both were diagnosed to have Schaaf-Young syndrome, and the couple are non-consanguineous, and there is no other family history. So they wanted to have a normal child, and they had come for preconceptional counseling. So this Schaaf-Young syndrome is an imprinting genetic disorder. In this Schaaf-Young syndrome gene, this MEGEL2 gene is encompassed within the Prader-Willi-Angelman imprinting region. So in this imprinting genetic disorder, the maternal allele is imprinted, means it is silenced, and the paternal copy of the gene is kept active in the children. So two affected children means that the paternal copy in both the children were mutated. So it must have come from the father. So carrier status of the same variation was advised in the father. And if he is a carrier of the same variation, then the recurrence risk in each future offspring is going to be 50%. So this variant in the father may have been inherited from his mother, or it might be a de novo variation which occurred in the father. He himself is normal because his paternal allele is intact and only his maternal allele is mutated.
We'll go
So
back to the
this
pedigree
is the genetic
once.
counseling which,
Yeah.
yes.
So here, if you're looking, so what she's told us is that both of them have the same heterozygous mutation in one particular gene, MAGEL2 gene, and that is consistent with the phenotype. So when we are looking at heterozygous mutation and that is manifesting, means we are thinking of basically autosomal dominant disorder. So any disease which manifests because of a heterozygous mutation, that is a mutation in one of the two copies of the gene, that is an autosomal dominant disorder, whereas a disease which manifests when both the alleles or both the copies of a gene are mutated is an autosomal recessive disorder. So here, this situation is actually something which is very, very different. So if you just look at the genetic report and then we'll be wondering that two children are affected with the autosomal dominant disorder, but the parents are healthy, like how has this situation occurred? So again, for many autosomal dominant disorders, this also is possible because what happens is that one of the parent may be having the mutation in their gonadal cells, but not having in the blood cells. We call this phenomena as gonadal mosaicism. So in this case, parents are healthy, but their two children or more than two children are having the same autosomal dominant disorder because actually the mutation is there in the gonad of one of the parent. So this is commonly seen for conditions like osteogenesis imperfecta, the type 2, which we see in the prenatal settings. So, but here we have something even more unusual. So what we have is that this gene, this causes a mutation. The mutation in this gene causes an effect only if the father gives it. If it comes from the mother and the mother's copy of the gene has a mutation, then there is no effect on the individual. So this is basically a reflection of a phenomena of imprinting. So commonly you would have heard of imprinting disorders like Beckwith-Wiedemann syndrome, Prader-Willi, Angelman syndromes. So where again it depends from where that particular deletion or other phenomena like uniparental disomies are happening, which parents' chromosomes or which parents' genes are involved, that determines the phenotype of the baby. So, but most of the times, these kind of imprinting disorders like Beckwith-Wiedemann or Prader-Willi Angelman, they are sporadic. They do not really have a high recurrence risk because they arise from some other mechanisms like uniparental disomies and all, which don't recur. Whereas here we have an imprinting disorder where most likely the father also has the mutation and he has passed on the mutation to his both children. And because the mutation is there on the father's copy of the gene, that's why they have the disease. And he's healthy. Why is he healthy? Because for him, the copy of the gene which has the mutation has probably come from his mother. So when the mother gives the mutation, the person is not affected. When the father gives the same mutation, the children are affected. So this is an example of an imprinting disorder with a high recurrence risk. So that's a very unusual scenario. Sometimes even in Beckwith-Wiedemann syndrome, we can have a situation whereby there is a mutation in the one particular gene, CDKN1C gene. But when it comes from the mother, then only the disease happens. If it comes from the father, the child will not have Beckwith-Wiedemann syndrome. So that is also another rare scenario where there is a recurrence of Beckwith-Wiedemann syndrome if the mother has a mutation in that gene. So these are some unusual pedigrees, unusual scenarios which we come across sometimes. So we need to keep in mind if things are not fitting. So if they're not fitting into the classical inheritance pattern of autosomal recessive, autosomal dominant, X-linked recessive, then that is the right time to refer to a geneticist perhaps for these complicated pedigrees where we would have some other unusual phenomena going on and where this would need more further counseling, further workup for those families. So I think that's the last case, Dr. Rupa.
Yes, ma'am.
Okay.
So from these pedigree analysis, the take-home message is that we can identify inheritance pattern, which helps in diagnosing the disease, identify attractive and providing and finding the obligate carriers so that even the proband, if the proband is not available, the obligate carriers be offered. And it also helps in cascade screening in conditions such as hereditary cancer syndromes, inherited cardiomyopathy, where we can offer the testing, and so that these people can be who are pre-symptomatic can be put on a surveillance plan and decrease and understanding the choice working diagnosis and identifying at-risk pregnancies needing prenatal is possible through a pedigree analysis. So thank you one and all for giving this opportunity to present. Thank you.
Shagun, there is a question. They want you to explain the imprint again, if possible.
Sir, we will do another class on that, I think, because imprinting is a very tricky phenomena to understand. I think we'll need some diagrams and we'll show some representative cases just for imprinting. So probably after Dr. Chinmay's fetus outside uterus, we are going to do the next one. We'll take up this.
Every time we take a topic, we feel this is very basic and we are just going to finish with the basics. But then when you look at the basics, it becomes longer, and it keeps on stretching.
So true. Kurana
So
sir,
your comments.
your comments, please.
Well, there was this, of course, one answer that you put into the chat box, that this is just a polymorphism if we have a 46XY 21PS plus. So that we don't have to be worried about. There are two ways in which we can handle pedigrees. Either that you give up, this is beyond me, I shouldn't get into this. But the question is, if you just spend a little bit of time, attend one webinar like we had last month and one like this, we can really get somewhere, and it's not really that tough to learn a bunch of squares and a bunch of triangles. It's just a question of overcoming a mental block that most of us have. The fact that we're trying to differentiate between learning by rote or learning by understanding, and that when you look at a pedigree, what should you do? And so that is one aspect, that you just have to open your mind, and it's possible. The more you do it, the faster it becomes, and you don't have any hassles. The second, of course, is that we need some artificial intelligence. And as I keep speaking, or my patient keeps speaking, there is a little recipient speaker that keeps on hearing, and artificial intelligence turns out a nice, beautiful pedigree for me without having to go beyond the grandmother anywhere. And the patient is telling the story, and AI is just doing this. And I'm sure that's not far either. I know two companies, one in Korea who's working on this already, and hopefully there's some work going on at Oxford as well. So for those of us who find it very difficult to handle this with human intelligence, artificial intelligence is going to come to our rescue, which I think is the way forward for those of us who think we're too old or that we can't handle this. But truly speaking, if you go step by step, there is no way that you would be able to manage most cases. I would say even more than 9 out of 10, just by looking at this. And then it becomes amazing how by looking at one little figure, you don't think of, okay, this is autosomal dominant or recessive. No, you immediately know that, okay, because this is this, therefore this is this. So that logical way is something that we must really learn. Otherwise, we never learn how to handle counseling in these particular individuals. So overcoming that mental block is really step number 1, 2, 3, 4, and 5. Thank you.
So, Dr.
Absolutely,
Chinmay?
sir. So
Impact.
no, there's hardly anything to say after the masters have spoken. But really, I think you took us step by step, and like this was the deep dive. We started with, because the whole concept is roots to wings. So we started with the very basics of the circles and the squares, and we started with how we were drawing. But today, I think Dr. Shagun took us step by step, and really drew it for us. That whiteboard idea was brilliant. And the way you took it step by step from the history, and how you generate that pedigree, and how the pedigree then gives you that information. I'm sure a lot of, because many people were having problems with the whiteboard, because they were also trying to write on it and do things like that. But I'm sure they'll all go back and practice, and this is really, really nice. Vimal sir, your words, please.
Yeah, this is amazing stuff. I just have an example to tell you what impact this is. I had a patient on Saturday for an opinion for echogenic kidneys. Whoever had done the previous scan, at the end of the report on the side with a handwritten, a short pedigree was plotted. I called him to appreciate him and I said, wow. So then he said, Kidney sir, wo last webinar se thoda question kar raha hu." I think eventually that's the impact factor. And if this can happen in a small town, with I like in continuation with what Sir said, somewhere you have to begin. And if you start off, like Sir said, it's not, yes, majority of the cases it would be possible, but somewhere people, and I think these two, the Mission Mangal episodes on, they were just amazing, very, very amazing. And there are a few requests in the chat box whether this will be available. Yes, we have a academic council which will just go through this, and once they approve it, we probably would have it on our website. But that definitely will take some time. But yes, I know. I would like to listen to this 2 episodes again and again, maybe especially the last one.
Thank you, sir. That
Thank
is
you
so
so much,
humbling.
sir.
No, thank you so much for encouraging us. And we know we have these wayward ideas, but then when we put them all together, it actually takes shape. And I think I have to thank Dr. Shagun for, holding our hand through this. So I
Thank you,
think with
Dr. Chinmay. Yeah. Thank you, Kuran sir. Thank you, Vimal sir. Mohicha sir is there, sir. Would you like to also add?
No, I just loved it. The way, as I said, Bimal said, I need to repeatedly listen to it till I actually start inculcating into my clinical practice. But amazing job, Shagun. Amazing job, team. The
Thank you, sir.
concepts that you brings in so much of freshness to the webinars. It's amazing.
Thank you so
thank
much,
you.
sir. Thank you.
Thank you so much, sir. And Dr. Shagun, will you just propose our formal vote of thanks, please?
Yeah. So
We're all
once
feeling
again,
very
thank you.
thankful.
Thank you everybody for joining. Thank you for all our seniors who are here always to, as I said, I mean the first meeting, I think, to launch our rocket every time. So I would like to start by thanking the MCs of today's event, Dr. Madhuri and Dr. Sahiti. And then my thanks go out to Dr. Priya, who actually had I mean the last session also she was supposed to present and I'd requested her, but then she had some emergency, couldn't do it, and she redid her whole presentation again when I asked her just 3 days back. So I'm really thankful to you, Priya, and you have brought in some really interesting points and given people the window into making an easy pedigree through using online softwares. So thank you for your presentations. And then I would like to thank our chairpersons, Dr. Ramita and Dr. Sandhya Rani Madam, for chairing the first session. Thank you to the 2 participants, of which I think one of them, Dr. Bindu, dropped off. I think some connectivity issue, but thank you, Dr. Rupa, for taking it forward, for compiling those cases, for making all those pedigrees as you did. And thank you everybody who stayed on some 20 minutes beyond our closing time. So, and thanks
And
for the
our
trade partners, our trade
Dr.
partners.
Madhuri and Dr. Sahiti. Our MOC
Sorry?
is Dr. Madhuri and
Yeah,
Dr.
I've
Sahiti.
already did,
Okay.
but I'll do it
Thank
again.
you.
So, Dr. Saiti and Dr. Madhuri, of course, for
And
the support throughout the program, conducted it so seamlessly. And Vishal, as always, and our technical support team. So, thank you everybody for today's webinar and staying on.
thank you.
Well done. Excellently done.
Yes.
Thank you, Dr. Chinmay Madam and Shakurana and Dr. Shagun.
Thank
you,
you,
Dr.
madam.
Thank
Thank
you,
you for
Dr. Sandhya.
joining.
Thank
Very
you.
excellent. Thank you, madam.